Good afternoon, everyone.
We are so pleased and privileged to have with us this afternoon Dr. Paul Esteso, our pediatric cardiologist from Boston Children's. Dr. Esteso is the director of the Cardiac Neuromuscular team at Boston Children's and has been closely working with our patients with Duchenne and Becker muscular dystrophy and the other muscular dystrophies, cardiomyopathy. I have had the privilege of working with Dr. Esteso while I was at Worcester because we share patients and we care coordinate. He's fantastic, and I am really looking forward to this session for Dr. Esteso to update us with the latest advances in cardiac care, and I'm looking forward to learning from him. So let's give Dr. Esteso a very warm welcome. Here you are.
Thank you very much. I'm humbled to be here with all of you, and just thank you for giving me the opportunity to talk to you. I'm going to tell you a little bit about how I think about Duchenne's care in terms of cardiac care and what kinds of things you guys should be thinking about throughout the life of yourselves and your children. And we're going to have an opportunity to have some questions afterwards, so I look forward to hearing from all of you. So I won't belabor this much, but this is how I think about Duchenne Muscular Dystrophy. You guys know it's an X-linked recessive disease, which is characterized by chronic progressive illness, which really is based on multi-system muscular failure. We're talking about the skeletal muscles that move the body, the breathing muscles, and the heart muscles. And the clinical manifestations that you know well are delayed motor milestones and then loss of motor milestones, loss of ambulation, and though this is mutation specific and some of the wonderful medicines we've been hearing about are elongating this time, typically think about 12 years of age. There's respiratory compromise, and survival is too low. About 30 years old for patients born after 1970. We certainly see some people who live longer. The mean survival for Becker's is also not normal. And I think it's really important to think about the fact that even though women with dystrophinopathy have been called carriers, that's not entirely accurate, right? We see symptoms in about 50% of females with dystrophinopathy. Some of them can have pretty severe cardiomyopathy. And we have to realize that about 2/3 of moms, sisters can be affected, and that these can be familial mutations. What about dystrophic cardiomyopathy? It's absolutely critical to understand that 100% of our patients with Duchenne's are going to have cardiomyopathy. That means that they're going to have ventricular dysfunction, dilation. Many of them are going to have arrhythmias. And the heart muscle is going to be replaced by fibrofatty tissue. It is a severe cardiomyopathy, and in Duchenne's is now the leading cause of death. And this slide is dated, but this is data in patients with neuromuscular disease from 2011. And the dark line are people alive with their own heart since the time of diagnosis. The faintest line is death, and the dotted line are patients who were transplanted. The numbers are improving, and I think we have to continue to do better, but certainly it's an important cause of death. And this is, I think, why I want to talk about this. Understanding this reality is a critical responsibility for all of us, and it's an opportunity. And certainly we've been hearing a lot about advances, and we have to continue to work on those things so that we can do better for our patients and our families. How do we evaluate the heart? Every child at diagnosis, is my opinion, they should see a cardiologist. We are in Massachusetts now starting to screen newborns in the very short future. I think everyone should be screened at diagnosis. That means an echocardiogram, an electrocardiogram. And you might say, why would you want to see a newborn? I think that we need to start to educate families early. We need to start to support families early because they're going to get into Google, they're going to hear from all these things. And if we're not there to support those families, then who is? And I have a few patients who have severe congenital heart disease in addition to Duchenne's. And so if we don't find those additional comorbidities, then we're missing an opportunity to help those kids. I think you should start having routine visits at the latest by age 5. And I must say that some of these things that I'm talking about are upcoming recommendations that are being updated and should be published probably early next year. That as disease progresses, you're going to have more visits. And with this sort of primer, I want to set up expectations, and I'll do this throughout the talk for each decade. I think for the first decade of cardiac care in Duchenne's, you should be seen initially every 1 to 2 years until age 5, yearly thereafter with normal or mildly reduced function, and if the cardiomyopathy becomes more severe, you may need to be seen more often. I expect all my patients, and I tell all my patients, that right now the recommendation that's coming out is that you should be on prophylactic cardiac medications starting by age 8. I talk to my families, and I think that understanding what's coming allows us the opportunity to treat patients early, and I would advocate to start patients actually even sooner. We just don't have the scientific data to back that recommendation, but there are families who choose to start even earlier. I think these medications that we're starting are actually really safe, and with close monitoring and with thoughtful use, they can be both helpful and safe. I think that in that first decade, there's very low risk of symptoms and low non-zero chance of severe dysfunction. We monitor by echo. By the end of that first decade, we start doing cardiac MRIs. And once patients are on medication, we start doing blood test monitoring. And specifically for children who undergo gene therapy independent of age, we do closer cardiac monitoring. We knew that gene therapy has a lot of promise, and we know that there's a risk of myocarditis. What about systolic ventricular dysfunction? We know that it gets worse with age. The average age by echo at which children start to have cardiac dysfunction is about 15 years of age, and there are a few children less than 8 years old who can have severe cardiomyopathy. One of the patients I take care of showed up to me at 9 years old, and his EF was 33%, and he was on no cardiac medications. And so I would like to disseminate this information so that other families don't have that experience. He's now 4 years older, and he's been stabilized on medicines, but sort of wonder what the trajectory would have been if we would have been able to start medicines earlier. This type of dysfunction, ventricular dysfunction, is more variable in Becker's muscular dystrophy, and it doesn't correlate with a muscular phenotype, with a skeletal muscle phenotype. We could have young children with Becker's who have severe dysfunction. We know that on average they're going to have less dysfunction. Typically, systolic dysfunction is preceded by scar, by LGE on MRI, and on echo by abnormal diastolic indices. And what that really means is we look at a lot of things on echo. One of the things we look at is how easily the heart relaxes, and we see abnormalities in relaxation before we see abnormalities in systolic function in the squeeze. And as you all well know, the cardiomyopathy in Duchenne is slowly progressive. We know that we can stabilize it, sometimes improve it a little bit over time with medicines, even though the trajectory is still towards worsening. So what about cardiac fibrosis? We talk a lot about this with MRI. So MRI is a way to look at not only at how well the heart's squeezing, which echo does a pretty good job at, but it can look at what the heart muscle, what the tissue around the heart muscle is. And we use a contrast agent that we inject IV that allows us to detect scar and fat. When we talk about fibrosis, it's just really a fancy word for scar. And it's a very high quality image, and I would say is the gold standard for imaging patients with Duchenne's. The frequency is really hospital specific. My practice is to do MRIs every 3 years because I don't think that the fibrosis changes that frequently. I know programs that I respect and that I think are at the forefront of the field who do them every year. That just hasn't been my practice, but our recommendations are to do them at least every 3 years, starting as early as you can, as long as you don't need anesthesia. I don't think that you should be anesthetized to have a cardiac MRI in Duchenne's. We understand the disease quite well, and you certainly get more personalized medicine by being able to do these studies. But if your child has severe autism and can't tolerate a cardiac MRI, I just don't think it's worth doing the MRI, doing the intubation for that study. I do think that we should be more aggressive with some of the medications and the timing to start the medications to make sure that we get ahead of the disease appropriately in that circumstance specifically, but I wouldn't anesthetize them. By age 10, about 15% of children, a little bit higher than that, have fibrosis by cardiac MRI. And by 13 years, about half the children have fibrosis on their cardiac MRI. It can start earlier, it can certainly progress over time. How does fibrosis correlate with dysfunction? So this is a graph looking at how many segments on the x-axis or on the bottom line have fibrosis. And if you remember yesterday on one of the studies, there were multiple arrows pointing at pieces that had fibrosis. We divide the heart into many segments, and so if different areas of the heart have fibrosis, we call those segments. And what you see here is that the more segments you have, the lower the heart function in general. We also know, and this study helped us understand that steroids not only help ambulation, but they help reduce the progression of cardiomyopathy in Duchenne's. Now, this is the guideline recommended medical therapy for heart failure with reduced ejection fraction in adults. And I love this graph. And what that graph tells you is what is the hazard ratio, what is the likelihood of cardiovascular mortality. What is the likelihood that someone's going to die from their heart disease in heart failure with reduced ejection fraction? So someone whose heart's not pumping well, and this is in adults. And all those little acronyms are the medicines that we talk about. ACE inhibitors or ARNIs are about the same thing. Beta blockers, MRAs are things like aldactone, and SGLT2 inhibitors. And what you notice is that the more medicines people are on together, the lower the likelihood of mortality. And these 4 medicines that you see at the top, whether it's an ACE inhibitor or an ARNI, which is Entresto, beta blocker, aldactone, SGLT2 inhibitors, are the medicines that eventually, I think everyone with systolic dysfunction should be on. So what's the guidance for cardiac care in Duchenne's? So there's a lot of documents that have given us some idea of how to progress in our care with Duchenne's. The American Heart Association had a statement in 2017 published in Circulation. There's a care considerations from 2018. We published in Action, and Action is a quality improvement group that's dedicated to heart function in kids. Started with the use of ventricular assist devices and trying to reduce stroke, and it has expanded to heart failure and now to Duchenne specifically, but dystrophic cardiomyopathy in general. And here's our recommendation from Action as to how we should use the cardiac medications in Duchenne's, and we turned that into a white paper published, I think, last year. And we're now working across the disciplines with the old care considerations standard and rewriting the guidelines for care for Duchenne's across all organ systems. And I expect that those are going to come through next year. And this is where that 8-year-old age suggestion for prophylactic medications come from. I'm going to tell you a little bit about the medicines, but I don't want to spend a lot of the time on the talk on this. But the first cardiac medication that you should use in Duchenne's is an ACE inhibitor. Lisinopril is a great example of a once-a-day medicine. It reduces the risk of progression of cardiomyopathy, reduces fibrosis, helps what we call reverse remodeling, which is sort of keeping the heart strong and tight, and it helps maintain or recover heart function or ejection fraction. Like I said, many families select to start early, but I certainly promote to start at least by age 8. And recommended always, independent of age, if there's fibrosis of cardiac dysfunction. A lot of families like to ask about Entresto, and Entresto is a perfectly good alternative. There's been trials in adults and children. The trial in children was compared to an ACE inhibitor, and they did just as well. They both reduced NT-proBNP. They both promoted reasonable function. They didn't have a control group. The control was the ACE inhibitor. But they're both recommended in children without one being better than the other. Entresto gives you a little bit more hypotension, but it's a little bit nicer on the kidneys. But it can be sort of patient to patient. In adults, there's a recommendation to use Entresto over ACE inhibitors. The reason we feel comfortable going down to age 8 years old as far as a recommendation is from progressive data from NSTAR, and this data from a French registry that reported on almost 700 kids retrospectively who they have on their national Duchenne program, which demonstrated that patients in a propensity match study who were on ACE inhibitor versus not had lower hospitalization for heart failure rates and lower mortality. We have mineralocorticoid receptor antagonists, and class independent. We show that there's improvement in heart function and scar as well. And so this is a second prophylactic medication that I would expect to start. We typically started a year or two after you start your ACE inhibitor. We recommended start by age 10, and certainly at any point that there's fibrosis and or dysfunction. So that sort of gets us through the first decade. What are the expectations for the second decade, so the 10 to 20-year-olds? We see those kids every 6 to 12 months, depending on the degree of dysfunction. We do annual echoes, and we do MRIs every 1 to 3 years. And if you're doing MRIs less frequently, they're all with LGE. If you do every year MRIs, they're not with the addition of LGE. At this point, I would expect people to get to the point where they need a third and sometimes more cardiac medications. Sometimes not only are we supporting their function, but we're preventing arrhythmia, we're preventing thrombosis. And one of the realities that we're hearing about throughout this weekend is that there's all these options of medications. And thinking about how to use them together is going to be really important in this coming decade. There's, by the time you're going from 10 to 20, moderate plus severe of severe left ventricular systolic dysfunction and the possibility of evolving heart failure. Now, heart failure in Duchenne's is really hard to tease out. The symptoms of heart failure, of breathing difficulty, of getting tired, of muscle pains, of digestion, can all be part of the Duchenne's. And additionally, as the body muscle has less ability to move, as children, young adults are doing less, they're asking less of their heart. So in a way, they're sort of adapting to the less capable heart or masking their inability of the heart to sort of augment cardiac output. And that's good in a way. They're not asking more of their hearts. We're not asking more of their hearts that they can do on a day-to-day most of the time. But it's really critical in illness when suddenly the heart has to do more and it's not able to do that. Certainly on medications, we do blood testing every year. And we monitor for arrhythmias. So starting at 17 or younger, if we see a lot of fibrosis, if we see dysfunction, we start sending yearly Holter monitors, or monitors that are looking at every heartbeat for a couple of days. So what is heart failure, to take sort of a step back? Is a clinical syndrome, so it's something that we can't diagnose with a blood test or with an echo, but it's something that the patient's experiencing and that we can get symptoms to show us that it's happening. That's driven by the heart's inability to meet the body's hemodynamic and metabolic demands while maintaining normal filling pressures. So what that means is the body can't do what it needs to, and this is where if your muscle capacity, if your running capacity is lower, then maybe the heart can still keep up. But if you have pneumonia and you have a fever and you're trying to breathe faster and you get fluids in the emergency room and you're trying to accommodate that, then that heart failure really shows up, really comes out. It sometimes is associated with structural heart disease. That's not the case in most of our patients with Duchenne's, but it's really associated with that functional abnormality. And when we think about it from a sort of cardiologist standpoint, we think about two things. Is there edema? Is there too much fluid? And how's the perfusion? Is there enough blood pumping? In dystrophinopathy, like I said, the skeletal muscle trajectories are not linked, but they're both getting worse together. The typical symptoms, like I said, can be masked. In the respiratory difficulties may be just progression of the diaphragm being weaker, of the intercostal muscles, or it might be heart failure. This is a key point that I want you to remember. Abdominal pain, progressive abdominal pain in a patient with Duchenne, particularly non-ambulatory, is the most prominent symptom of heart failure. When I see kids who are getting sicker from their heart, they don't have symptoms, that's all okay. If they start having progressive abdominal pain, that's one of the things that makes me really worried. And that's the early and most prominent sign of heart failure in our patients, and sometimes it's a reason that they need more intervention. To get a little bit back to the medicines, beta blockers are medicines that help slow down your heart. We got to use them carefully because the body accommodates for that less ability to pump with each beat by pumping more often. So we have to be really thoughtful about how we use these medicines, but they certainly reduce mortality in heart failure, would reduce ejection fraction, so we use them thoughtfully. There's also this idea out there that people have sort of so many heartbeats, and if you're beating a lot, having a lot of heartbeats, and there's a contraction-related muscle damage, that having those abnormal sinus rhythm that many of our children have, where 12, 13, 14-year-old might have a sinus rhythm, a normal baseline rhythm in the 90s, 100s, 110s, that abnormal sinus tachycardia might be contributing to progression. So we recommend it certainly with arrhythmia, with dysfunction, and we think about it with this abnormal sinus tachycardia. The fourth medicine on our pillar, and this is a fourth medicine that as the disease progresses, I'm asking my patients to think about. Sometimes I add SGLT2 inhibitors before beta blockers, but this is a relatively newer class of medications. It's been around for about 10 years. There's extensive data in adults about reduction of heart failure mortality and hospitalization, but pretty robust data for heart failure mortality, both in systolic and diastolic heart failure. Is really the only medication that has good data for, it's really a composite of heart failure, hospitalization, and death, and what we call heart failure with preserved ejection fraction. So really the heart's inability to relax. And it works by a lot of separate, interesting mechanisms, which I think would be important in Duchenne's. It works by reducing the negative effect of reactive oxygen species. It works by improving the way the cells handle energy, and has been demonstrated in children, and we just published a series out of my group, and there's a couple of other series coming out, and we're actually working on a series on patients with Duchenne's from ACTION. It's a safe medication, and it can improve heart failure. It can improve heart failure symptoms, can improve ejection fraction, and it can reduce NT-proBNP, which is sort of one of the markers that we use. We certainly recommend it on every patient with Duchenne's who has an ejection fraction less than 40%, and there are times when I recommend it when it's higher. It can be considered in mild dysfunction. It is a weak diuretic, so it's one of the things I tell my patients. I don't use diuretics early in my practice, but others do in Duchenne specifically. So if you're already on diuretics, or for our older patients who don't like to drink and don't like to pee, I think it's important to know that it's a weak diuretic. There's a low risk of infection and urinary or general urinary infection because you're peeing more sugar with this medication, and it helps with diabetes. It long-term helps your kidneys. So there's a lot of good reasons why I think it's an important medicine in Duchenne's. And we've been talking for a long time about trying to do a Duchenne-specific trial of SGLT2 inhibitors, and it seems like we're getting closer to that. So what is sort of our general treatment algorithm for Duchenne's for our patients? I like to start medications early. I like to consider Duchenne-specific side effects carefully, and I like to partner with families in trying to optimize care, and in considering all the other things you guys are being asked to do. And in the green here, we use ACE inhibitors and MRIs for prophylaxis. We use beta blockers when there's tachycardia, and those are medicines we use without dysfunction. When there's some dysfunction, I use SGLT2 inhibitors. And like I said, I often use them before beta blockers. What about novel therapies? I'm thrilled to see the data from all the companies and see the involvement. I know that you guys have been a part of that. And there's all these therapies. And we don't really know what the long-term effect of any of these medicines are going to be. I'm excited to see some of the data that is coming out, and I applaud the companies that are looking specifically at cardiac outcomes. And I think I would encourage the companies to do so by doing MRIs. I know it's hard. Maybe you can partner with clinical care for long-term monitoring, but I think it is critically important for us to understand what the primary cause of mortality, how the primary cause of mortality is being affected in our children with all these new medicines. I think that we need to consider DMD-specific side effects, and we need to actively monitor patients. I love that all these companies have all these databases that you can be part of, and I think it's important to do long-term follow-up. Like I mentioned earlier, I formed part of an organization called Action that's specifically trying to understand how the heart is responding in Duchenne's and how the heart is responding to all the things that we're exposing our kids to. We started our registry in 2021, and we have over 1,500 patients now. We are collecting data from 34 hospitals, and the line at the bottom is how many of those patients have entered follow-up. So we're getting data from patients, or directly from the providers, actually. The patients just have to consent. We don't ask them for any extra tests, any extra blood, any extra visits, but we enter the data into the registry about every 6 months. And that's the data that we've been using to publish a bunch of papers to think about the guidelines, and to really try to bring out the signals of safety concern as we combine these medications. What about blood monitoring? We know that monitoring renal function is really important. CK can be nephrotoxic, and not drinking enough water because you don't want to pee over time can be nephrotoxic. And cardiac medications can be nephrotoxic. And so all these things over time are starting to accumulate into renal dysfunction. Renal dysfunction that's masked because there isn't a lot of muscle, there isn't a lot of creatinine. So we need to be really thoughtful, start checking cystatin C, and think about how we're managing fluid in our patients. Think about why, like Dr. Wong mentioned earlier, their feet are swollen, and how's their salt intake. We need to look at their electrolytes, which affect the risk for arrhythmia, and we need to look at NT-proBNP with every visit. NT-proBNP is more sensitive than BNP, and while it's not elevated often in Duchenne's, when it is, it's another marker that we really should be thinking carefully about the heart. Troponin I should be evaluated in every Duchenne's patients with chest pain. There's this entity called dystrophinitis that we don't totally understand, but when even young patients with Duchenne's have chest pain, they can have a step down in their cardiac function. They can acutely develop fibrosis. They can have huge elevations in troponin that are transient. Sometimes happens after viral infections. Sometimes we don't know why. There's changes in EKGs that make a lot of people take these children to the cath lab. It's never been associated with a blockage into an artery. So if you're experiencing these things, yes, you should be monitored, but if someone's trying to rush you to the cath lab, make sure that you're talking to your primary cardiologist, talking to a center who understands Duchenne's, because it might not be where you land at that time. The other thing is that troponin T, we have for a long time used it as a marker of cardiac dysfunction or cardiac injury. But it's leaky from the body muscles. And so kids with Duchenne's have transient elevations in troponin T that don't represent heart injury at all. So if somebody tells you that there's heart injury and all they're looking about is troponin T, you should say, hey, what about troponin I? I don't think that that's as good. And I'll tell you that colleagues in my department weren't aware of that until recently. So at the best centers, there's still some information that I think I try to empower you to be the bearer of. And there are some of these markers that are associated with mortality in Duchenne muscular dystrophy, NT-proBNP, the mean inspiratory pressure, and body mass index. And I think as we go along, there's actually new data that's either out recently or coming out that chronic low-level elevation in troponin I is associated with a progression in cardiac dysfunction in our kids. What about advanced cardiac therapies? So here we're really talking about VAD, we're talking about transplant, we're talking about more advanced things. This is a paper also from Action looking at VADs in patients with neuromuscular disease. And there's a couple of patients with Duchenne's and Becker's in here. So as heart failure progresses, symptoms may become refractory. This is sort of end-stage heart failure. Also, with severe dysfunction, even if you don't have any heart failure symptoms, you're at risk of getting a clot, particularly a clot in the heart. Clots in the heart can go really bad places. So sometimes when you get really bad dysfunction, you need an anticoagulant or an antiplatelet therapy. I worry a little bit about anticoagulants because many of these are non-ambulatory kids who have wheelchairs, who can't move from a sore spot, who have more risk of bleeding, but sometimes aspirin is important. There's also, over time, increased risk for arrhythmia. We talk a lot in this community about defibrillators. And what I'll tell you is that while we've put on a bunch of defibrillators, I don't know of a single kid that's been shocked out of a rhythm who's been alive afterwards. Mostly the arrhythmias that kids have are bradyarrhythmias or arrhythmias associated with metabolic disease at the end, and they have sudden cardiac death, many of them with defibrillators that never fired. It doesn't mean no one should have a defibrillator, but it means that you have to have a really critical and thoughtful conversation with your cardiologist about whether defibrillators are the right therapy. And we as cardiologists have to think very carefully about which kids should have a defibrillator. We certainly should do medications to reduce the risk of arrhythmia, and we often do, and beta blockers are one of those medications. And then what about VAD? I think all of these advanced therapies, there are kids with Duchenne's who should be considered for ventricular assist device for transplant. They have to be selected kids. So in this data, there was 18 patients included who had VADs. 12 of them had dystrophinopathy. 8 of them had Duchenne's, 3 Becker's, and 1 was a female with dystrophinopathy. Of the patients who had Duchenne's, 2 had transplant. Of the patients with dystrophinopathy, 2 were transplanted, 4 had deaths, and there's 6 who are alive on device. And this is over several years. In talking to these investigators, they're still alive on device. I think that there are many institutions who are afraid to use these therapies in patients with Duchenne's. There's starting to be some momentum to change that, and there's some extra data that's coming out that I think is going to help us. And we have to be really thoughtful about which patients should have these therapies, because just because we can do something doesn't mean we should. And if we can't make your child better by offering this big therapy, then maybe we shouldn't do that. But it doesn't mean that it's not at all a possibility. What about transplant in Duchenne's? It can be a possibility for selected patients. We must admit that we have limited experience and no guidance on when we should proceed. One of the cutoffs is if your percent predicted respiratory function is less than 30%, that's a very risky scenario. So most patients who've been transplanted, had a VAD, successful, have respiratory functions better than 30%. And there's the risk when you do these big surgeries of making things worse, making your ability to eat worse, making inability to get off the ventilator and talk about trach. So these are all important conversations. But there are success stories. And this is data that's coming out of ACTION as well, that's unpublished. But we have 25 patients with neuromuscular diseases, 6 with Duchenne's, at a median age of, the Duchenne's, a median age of 16.6, 20% of who had complications, but of all these kids, they're 89% alive at 5 years. And when we compare the survival curves of these very select patients to all the other patients, pediatric patients that we've done transplants on, they actually are doing better, but we're being very select. So what about the expectations for the third decade? We're gonna see you more frequently. You're gonna have the same kind of testing, but more often. It is quite possible that these kids are gonna be on multiple cardiac medications, and depends on all those things I was talking about. There's likely severe dysfunction and that difficult to find heart failure. One of the things I really want to talk about is, and I'll give you a little anecdote, and I'm talking too long, so I apologize, but I had a patient who was an adult with severe dysfunction who went to an outside hospital with kidney stones, and they tried to operate on him. He called me before they went to the operating room and said, "Can you help me?" And the proceduralist from that hospital came into the room. He said, "Talk to my cardiologist." Thankfully, that surgery never happened. I was like, "Is this an emergency?" "No, but he's uncomfortable." I'm like, "You're gonna kill him." It's like, okay, I won't do it. Great. When you go to an outside hospital, when you go to your own institution and you haven't talked to your people, if they're asking you to do something that doesn't seem right, if they're asking you to get 3 boluses, maybe that's what you need, but you shouldn't do that without talking to your team, because those responses that for most people might be life-saving might be complicating for our patients. The other thing, I was talking to a family yesterday, and the mom told me, well, I sometimes don't know when to call. If you're thinking that you should call or wondering if you should, just call. What's the worst thing that can happen? We tell you you didn't need to call, and next time you call us again, and we say it again. But that's okay. We're invested in taking care of your families, so call us. And we monitor for arrhythmias in the 3rd decade. Respiratory support is really helpful to the heart. So if you're wondering if you should go on BiPAP and you're worried about the heart and not about the lungs, go on BiPAP. So as a summary, cardiac care in Duchenne's is lifelong. Dystrophinopathy is going to happen. The medications can be helpful, both prophylactically and in long term. Dysfunction is typical in adolescents. Most are asymptomatic. But if you see abdominal pain, not that I had sushi yesterday, I ate too much, I didn't feel great afterwards. That's not what I'm talking about. Progressive, persistent abdominal pain, you should talk to your cardiologist. Select patients benefit from advanced therapies, and we need to be really thoughtful about what those are and when. We don't know about the cardiac effects of the medications and certainly the combinations, but we really need to be thoughtful about doing trials, making sure that those things are working, and being part of registry so we can understand this better together. Thank you.
Thank you so much, Dr. Esteso, in covering the entire spectrum from the newborn right down to our new generation of 30-year-olds, 40-year-olds. And you hit the point in that it's teamwork, right? The BiPAP that can help the heart, because we have a lot of resistance from our patients that need BiPAP to get that started. But when they do understand, it does help the heart at night when they sleep, they're more willing to try. So I think that's a point where it's teamwork. We get the cardiologists and pulmonologists and neuromuscular doc at the same time. So that is a great practical point to highlight that does impact a lot of changes at this point in time. Yeah. And I think with our older population, this whole era of advanced therapies is something that is new for our discussion. So I think at this point, I would like to open this to the floor for questions and answers that Dr. Esteso can address.
Yeah, thank you very much. I get a couple of quick questions. One is, we have a lot of young men today who are between 10 and 16 who have started on lisinopril and Plerinone and a beta blocker when they were 8 or something, right? Mm-hmm. So when these young men are, hopefully into their 30s, do you anticipate that the future will look like more of these VAD devices or replacements, right?
Yeah, I think it's a really good question. And while I strongly advocate for the heart medications, I don't think they're going to be enough.
Okay.
And so that sort of gets to your question. We still see progression of cardiomyopathy in these patients. We still see fibrosis. We still see dysfunction. We are hoping to affect the trajectory, the slope of the curve, but we're not affecting the underlying reality that there's ongoing progression. That's what I'm hoping the combination of therapies is going to be able to do. And hopefully we'll be able to step off some of these heart failure medications from starting when they're young, when we actually have truly disease-modifying drugs.
So then, with that being said, the disease-modifying drugs, obviously there's a PDUFA date for the Capricor, which is geared towards cardiac function, right? Mm-hmm. The progenitor cells or whatever, something like that. if it continues to be effective like the data that we've seen, you anticipate something like that along with other treatments or something. I'm not asking you to speak on behalf of this drug.
No, I hear. So I did my PhD in stem cell biology. I had a lot of hope for stem cell biology, and I think there's truly a role for it, a space for it. I don't know if it's gonna be, and these are not stem cells, and I'm not talking about Capricorn specifically,
Nope.
but I think that what we really need is gene replacement therapy. I think we need to really change on every cell the underlying problem, and all these clever ways to modify the downstream effects of the absence of dystrophin are critical, but they're still not the problem.
No. And just finally, one last thing before I hand it off. There are all these smart devices like the Oura Ring or the Fitbit. Do you think there's any value in that?
I think that we know, so I don't think that they're going to detect an arrhythmia in a useful way unless that arrhythmia is atrial fibrillation, which can be in Duchenne's. I think that we get pretty good with our EKGs and our visits are seeing where the baseline is. So part of the question is like, do we need a more sensitive way to detect arrhythmia on an ongoing chronic basis? And I think the answer is no, but I think we need to be doing those yearly heart monitors to make sure that we're capturing enough and wearing them for, sometimes this is hard for our more sensitive children, but for 3 or 4 days to really get a picture of what's going on. And go ahead. Yeah, and the technology is improving so quickly that it's not as cumbersome as it used to be.
Wait for the mic.
Thank you. You talked about the MRI. You are preferring it every 3 years, for example.
Mm-hmm.
For example, if my son had MRI this year, he is almost 15 years old, and they didn't find out a fibrosis replacement, for example. In how many years we will wait to see in the next MRI? For example, how many years we will say, oh, okay, we are good.
So these changes, evolution of fibrosis, is a slow process, right? It's happening at the cellular level, and it's accumulating little scars that build up to enough to see with the MRI. In the absence of one of these dystrophinopathy episodes, which really means chest pain, a big troponin change, it is unlikely that we see 0 to 100. It is generally incremental. And so having a baseline, that's why I feel comfortable doing them every 3 years, because I think that the changes are unlikely to be monumental. When someone has had gene therapy, when there's an introduction of a completely different system and a completely different risk, then after gene therapy, I like to get an MRI right before and then a year later to see how those things are changing. But in general, I feel like every 3 years gives you a good enough picture.
Yeah, I want to learn that. For example, we did it this year,
Yeah.
and after 3 years, if it is 0 today, after 3 years, for example, it will be 80% of fibrosis we will see in 3 years, for example. It depends.
It depends.
Okay,
And also,
thank you.
is he on spironolactone at this time? Because if he's already on that, then you're not so worried about missing it the next year, right?
Yeah, so part of the reason some people like to do MRIs because they like to time the initiation of some medicines to the MRI. The way we've moved the guidelines and recognizing both that there are centers that can't do MRI every year and that there's an evolution that's happening beyond the detection of the MRI, even though that's our best tool, is to really start spironolactone and an ACE inhibitor prophylactically. And so if you're not tying those medicines to the imaging, then there's less concern about how soon you can get the next one.
Thank you, Doctor. This is Navina Alampalli. I'm 20 years into AI technologies, building for enterprises and data platform. 2023, my son was diagnosed with DMD, and that's where things changed for me. And now I'm building technologies how to address long-term therapy monitoring.
Yeah.
He's the first kid in Texas to get the gene therapy, along with Hudson. There's another one, and that led me to think about long-term safety surveillance, long-term therapies monitoring, because I see him in multiple therapies, getting different therapies.
Yeah.
How do we ensure, working with the clinicians, building a technology for cardiologists, because it's multi-systemic, and understanding how the therapy is progressing, because every time I talk to doctors, the answer is, we don't know, we have to wait and see. And being an AI specialist, now we know what can be done. And that's exactly where we are thinking about building technology for cardiologists, where we can, instead of waiting, we can have answers way too ahead with all these tracking, continuous longitudinal monitoring, and safety surveillance. What do you think about these kind of technologies for every single specialist, whether it's cardiologists, pulmonologists, and an overlong safety surveillance and therapy monitoring? Thank you.
Yeah, I mean, I think these powerful AI platforms are really interesting and you know much better than I, but we're just starting to learn how to use them. And there's good examples in cardiology of looking at single lead EKGs, which you can get from your Apple Watch, and predicting meaningful congenital or valvular heart disease, even in children. And there's a study like that happening at Children's right now. And in Boston, sorry. To me, Children's is my everyday life, so don't say the whole name. I think that there is so much we don't know. We don't even know what the important signals are. And so what would be wonderful would be not to have Action have their registry, and Capricorn have their registry, and Cure Duchenne's have their registry, but to have Epic give you access to everyone's de-identified data with Duchenne's. And let us do our clinical care and look through all that multidisciplinary laboratory and imaging data at what are the black box signals that suggest progression, modifiable progression, or an adverse event. Because I don't even know where to start looking, right? And there's so much data, and every time I talk to one of my colleagues in a different specialty, I was talking to Dr. Weber, I learned something extraordinary and new. And so how am I, or you, or any of us, gonna be able to synthesize? We've been talking about 25 different drugs this weekend. So how are we gonna synthesize the risk of that? And so I think it really needs to be at a higher level, and I think really engaging Epic, who has all of our data, on how to do this would be, I think, the way I would hope we move towards.
Mine is not a question, but a public service announcement. We were a family that were a little nervous to be really aggressive with cardiac medications. And so just in case there's another family in this room that feels like that, it went really smoothly for us, and then we regretted that we were nervous. So I just wanted to say that in case somebody needs to hear it.
Thank you. And honestly, my approach when I meet a new family is to say, this is what I'm going to recommend, but we need to be partners. And you're the family. And every time I see you, I'm going to recommend the same thing. And if you don't feel comfortable this year, we'll talk about it next year. And I'm not deciding which of these medicines at which time, and I'm not privy to what else is going on in your life or what experiences have brought you to have that hesitation, right? But by and large, these heart medicines that I'm talking about specifically are safe medicines that I use on newborns with heart disease all the time, and with some reasonable caveats like if you're dehydrated with bad diarrhea, it's okay to hold your medicines for a couple of days. Or when we start, this is going to feel like that for a couple of days and then it's going to get better. I think that they're well tolerated. We have seen, there are side effects, right? SGLT2 inhibitors, which I adore, can cause hypoglycemia. And I've had symptomatic hypoglycemia in 3 patients, including a 15-year-old. That I would have thought she was lying, but her finger stick was quite low. And so there are real side effects. We have to give you the information of what to look for. But in general, they're well tolerated. And if they're not tolerated, nothing has to be there, right? I think all these things have cumulative advantages, but it's not a must.
And it's really nice to see that we have more evidence now from your data that these prophylactic medications are beneficial and impacting your trajectory, as you can see. We didn't have that like 15 years ago, 10, and I think that were the years when even doctors, cardiologists themselves were a little bit hesitant. Some centers were starting, some cardiologists were not. They were waiting for the first sign of, change, either in EKG or echo. So I think we are at a better place with the experience that we've had, and our cardiology colleagues are now working really closely. Years ago, it wasn't that close a collaboration. And I think personally myself, I have seen, like when I was at Cincinnati Children's in the beginning, we used to lose a patient to cardiac failure. Those were non-steroid treated kids. Like when they were 14, our cardiac transplant was when he was 15. And so it was almost like 1 patient loss per year or every 1.5 years. And then things right now, the 8 years at UMass, we've lost only 1 to very low EF, right? So it looks like it is kind of showing data to support the use that is easier for the families now. And I really am looking forward to now with the addition of SGLT2 that again, you're right, you're going to change the trajectory more. So that is hope in there. Yeah, that we are forever changing the outcome.
Yeah. While the microphone's coming, I'll just say that I have heard older cardiologists say, I just don't want to cause any symptoms. It's already so hard. And I don't want to make your life any harder, but if I know that these therapies have a potential of making things better, we can manage the symptoms or we can change medications, but not trying because I don't want to hurt doesn't seem like a good enough answer for me.
Yeah, my cousin's kid, who is like 11 years old, and he recently had echo and EKG both done, but the cardiology didn't recommend any medication. So do you have any suggestion for any, medication to put him on to make sure that he will not get into problem in the future? Maybe, you said like, use this before 10 to 20 you recommended something, and after 30 you have something. But the DMD patient, but with good heart echo and heart muscle. So any preventive medication which we need to take care of?
Yeah, if he's 11 years old, I would say that the current guidelines cover that suggestion, and so there's the 2018 care considerations, or we recommend it started by age 10, and our action paper, if you look at just cardiac medications, Duchenne's on Google, it'll come up, and I would walk into the cardiologist office with those papers and say, I'm hearing this from a lot of cardiologists, we are interested in starting medicine, what do you think? And if he's not able to support you, I would suggest finding a different cardiologist. I think that if he says, thank you, let's do this together, that's a great cardiologist that needs to learn, and you can be a vehicle for his learning and help other people that way. But if they're not willing to work with you and you're coming, humbly with some information, I think that's not a good situation.
Thank you. That really helps.
Actually, we did 2022, my son, cellular therapy in India. That is helpful to the heart muscles.
So, what type of cellular therapy? What therapy was it? I'm sorry.
Cellular therapy, stem cell therapy.
Oh, they do those.
Stem cell.
Yeah, I don't have any data to say. I don't know.
Is that the stem cell therapy from private clinics and not from the hospital? Is a private clinic?
Yeah, private clinic in India from Alok Sharma.
Yeah, I think we've had several Duchenne families in the past, since 15 years ago, that would travel to other countries, like, I think Ukraine was one, Dominican Republic was one, there's also one in Florida, and other countries that give an infusion of stem cells.
Yeah.
But that kind of stem cells is not like the regenerative stem cells to make muscle cells?
No, ma'am. Actually, we are not save the cord blood. Those are telling bone marrow to remove the cells, and wherever the parts are weak, that place induce the cells.
Yeah, so bone marrow derived stem cells or mesenchymal stem cells or c-kit cells. So there's a lot of different variants of cells that you can get from circulating blood or from bone marrow that are generally, that may or may not have an effect on muscle, that generally that have not generally been found to have a meaningful effect, and have not had, there's no reason to believe, and based on, I keep doing that, based on lots of experiments we did when I did my PhD, there's no reason to think that it would benefit the heart.
Thank you.
I'm not familiar, the SGLT2 or whatever, I don't know what that is. What triggers the use of that medication?
To me, it's heart dysfunction. It's, you might have seen all the commercials for Farxiga. These are medications for diabetes that in trials with diabetes were found to reduce heart failure and mortality. And there's been a lot of trials then looking at people without diabetes. And there's a lot of case studies, case series in pediatrics in heart function, starting to show some evidence, tons of safety evidence, but evidence of decrease in EF or improvement in EF and decreases in NT-proBNP. But it's medicine that, like I was saying, works in a lot of different ways, but reduces inflammation, reactive oxygen species, helps with energy utilization, and helps you pee shorter.
How long have this drug been used in this context?
So they've been around for about 10 years. We are putting together a case series in Duchenne's where we have 80 patients, and we've been using it in Duchenne's for about 3 years.
So it's something we should talk to our cardiologist potentially about?
I think if your son has dysfunction, it's something that I would bring up.
So normally when they are on the triple therapy, like the standard, and their function remains stable, is that just an indication to just kind of hold off and observe before you add on a fourth?
Yeah, it depends how bad the function is. It depends how much fibrosis is. Sometimes we can have extensive cardiomyopathy and the heart function looks normal by echo. And the walls of the heart are actually severely affected. There's a lot of the myocardium, the heart muscle has been replaced with scar and fat. And those patients are worried a lot about with any perturbation and getting sick and stuff. And we often can get them through, but we have to be careful. But patients like that, I tend not to add a fourth drug if the function is okay, but it's more of a conversation.
Yeah, thank you.
I have a question regarding if you have any research data or any experience or opinion on using these prophylactic medications in kids with DMD that also have comorbidity with chronic kidney disease. My child is in late stage 3 chronic kidney failure. So have you had any experience, or do you have any knowledge in this?
So not in DMD, but I'm a heart failure cardiologist, and the kidney and the heart like different things, and many of our kids with both congenital heart disease or complex acquired heart disease, cardiomyopathy, can be in a situation where their kidneys are a problem and their hearts are a problem. And it's a really tough scenario. I think those are exactly the kids in whom prioritizing an SGLT2 inhibitor, which might initially reduce your kidney function a little bit, but it's actually better for the kidney function long term, has no effects on blood pressure, has no effects on electrolytes, and has beneficial effects for the heart, might be a good medicine to think about. And a beta blocker can also be benign on the kidney. So it might be that for specific comorbidities, the order of operations is different. And if, depending on the potassium, I might not start an aldactone medicine, but with stage 3 CKD, I might not start. I certainly would not think about starting an ACE inhibitor or Entresto, but certainly beta blocker, depending on how everything's going, but would be a reasonable choice. SGLT2 inhibitor would be a reasonable choice, and those would be the 2 things I would likely start with.
And this brings me to mind that, especially for our older patients, when they have LV dysfunction that is significant, leading to cardiorenal syndrome, CKD, and things like that, that our adult nephrologist comes into the picture. So now, I've been on the phone with the cardiologist, I've been on the phone with the nephrologist, and then you bring them 2 together. So, it's like, again, it's an example of teamwork, and you have Dr. Esteso talking to the nephrologist, and so again, that is the needs of the older population, yes. But I find that finding a good adult nephrologist that you work with, that's willing to work with your cardiologist, that is key.
Thank you.
Maybe last couple of questions, since we've got the need to evacuate this room at 3:45. Any other burning questions for Dr. Esteso before we close?
I think, can I say one more thing about your son? I would encourage your team to think about kidney transplantation if necessary, and I don't think that if he's stage 3, he doesn't need it now, but I don't think that Duchenne should be a reason why kidney transplantation, especially with the fact that you can do directed donation and all these things, should be precluded.
Any more? I think if not, we can close this session and we'll give Dr. Esteso a good round of thank you. Thank you, Paul. Thanks so much. That was excellent.